Hello everyone, this is Dr. Naz and today I'll be discussing about atrial septal. Atrial septal defect refers to the direct communication between the atrial chamber. So during the early fetal development, the heart consists of a single tubular structure called the primitive heart tube. As the heart develops further, it undergoes looping and partitioning to form distinct chambers. So basically there will be a single large atrium and a single ventricle, and then the septation begins. The primary atrial septum begins to form around the 5th week of gestation as a thin crescent-shaped protrusion within the atrial cavity. The primary atrial septum continues to grow downward towards the developing ventricle. As it elongates, a small opening called the foramen primum forms at the lower part of the primary septum. The foramen primum allows communication between the left and right atria during fetal development. As the septum primum develops, another structure called the septum secundum begins to form on the right side of the septum primum. The septum secundum grows downward, partially overlapping the septum primum but leaving an opening at the top called the foramen ovale. The septum secundum continues to grow and eventually develop a thicker, more muscular appearance compared to the septum primum. The foramen ovale serves as a communication between the left and right atria prenatally, allowing oxygenated blood to bypass the developing lung and follow directly from the right atrium to the left atrium. After the birth, changes in the pressure and the oxygenation of the blood in the heart and lung prompt the closure of the foramen ovale. The septum primum and the septum secundum comes in contact with each other, sealing the foramen ovale and completing the formation of atrial septum. And if any of the defect occurs in these process, it will lead to atrial septal defect, and it will result in left to right shunt because there is a high pressure in the left side of the heart which leads to pushing the blood towards the low pressure right side, and it is due to pulmonary vascular resistance is less than systemic vascular resistance, and compliance of the right ventricle is much greater than that of the left ventricle. So you can see it is left to right shunt. The oxygenated blood from the left side of the heart is entering the right side of the heart because of high pressure in the left side of the heart. So there are three common types of ASD: secundum ASD, primum ASD, and sinus venosus ASD. Secundum is the most common type and it comprises of 90% of all cases of ASDs, and it occurs in the middle of the atrial septum due to the defect or deficiency or fenestration of the foramen ovale. The second common is primum ASD, and this type of ASD is located lower in the atrial septum near the tricuspid and mitral valves and adjacent to the atrioventricular septum, and because it is located near the valves, therefore it is associated with cleft anterior mitral leaflet and other valvular abnormalities, and it is also associated with Down syndrome. The third one, which is the least common type, is sinus venosus ASD, and it is located near the superior vena cava or inferior vena cava, where these veins are connected to the right atrium. In picture A, you can appreciate the normal formation of septum primum and an overlapping septum secundum. So in picture B, you can see there is defective resorption of septum primum. As we all know that during fetal development, the atrial septum is formed by the fusion of two structures, the septum primum and the septum secundum. The septum primum initially grows down from the roof of the atrium, and as it approaches the septum secundum, a small opening called foramen ovale is formed. This opening allows the blood to flow from the right atrium to the left atrium bypassing the non-functional fetal lungs. After the birth, when the baby takes the first breath, changes in the pressure within the heart causes the septum primum to be pushed against the septum secundum, closing the foramen ovale. Over time, the two septa fuse, forming a complete atrial septum. However, in some individuals, the resorption of the septum primum is incomplete, resulting in a patent foramen ovale. This means that there remains a small opening or flap-like structure between the right and the left atria. This can allow blood to flow from the right atrium to the left atrium or vice versa. So this happens when there is septum secundum or septum primum excessive resorption. Again, In picture D, you can see absence of septum secundum can lead to atrial septal defect, and then it is the most common congenital heart disease in adults, and it usually doesn't become symptomatic before the age of 30 years. Therefore, it is usually an incidental finding on routine clinical examination. The symptoms which may occur include dyspnea, chest infections, cardiac failure, and arrhythmias. The patient of atrial septal defect may show systolic ejection murmur alongside left sternal border due to increased pulmonary flow, and there is wide fixed splitting of S2. So in a normal heart, the closure of aortic and pulmonary valves, which makes up the second heart sound, occurs close together during expiration. This results in two components of S2 known as A2 and P2 being heard as a single sound. However, in the presence of an ASD, there is abnormal communication between the left and right atria, allowing blood to flow from the left atrium to the right atrium. This can lead to increased blood volume in the right atrium and right ventricle. Consequently, during inspiration, there is an enhanced filling of the right heart chambers due to increased venous return, which further delays the closure of pulmonary valve. As a result, during inspiration, the aortic valve closes earlier than the delayed pulmonary valve, resulting in a wide splitting between two components of S2. So the chest X-ray may reveal cardiomegaly and enlargement of pulmonary artery and pulmonary plethora. So when there is left to right shunt, there is increase in the blood volume on the right side of the heart, and over time the increased blood flow can cause right side to become enlarged and leading to cardiomegaly, and therefore there will be enlargement of pulmonary artery due to increased blood flow. However, these chest X-ray findings are not definitive, and other options should also be used, such as ECG and echocardiography. So the ECG shows incomplete right bundle branch block, and echo is the most accurate test. So the surgical closure of ASD is typically recommended when the defect is significant, causing symptoms or complications. The surgeon identifies the ASD and determines the best method for the closure. Various techniques including suture closure or patch closure using synthetic material or pericardium can be done, or minimally invasive procedures are also used. If pulmonary blood flow to systemic blood flow is more than 1.5:1, that is more than 50%, then surgical correction is indicated, and it has excellent prognosis if pulmonary hypertension hasn't developed yet.